So our next speaker, Dr. Stephen Diana, I actually met him through Dr. Hisham Shurigan and Elaine. And I think, as any dentist can say, there are so many implant courses out there. It can be pretty overwhelming to know which one to take. And so I decided to take one with Dr. Stephen Diana, and I don't regret it for a second, and I haven't looked back since. And so he's got a very successful practice in Georgetown, very implant heavy. And as a general dentist with over 20 years of implant dentistry experience, providing all aspects of treatment from sinus lifts, block grafts, GBR, immediate implants, and full arch treatment. He's going to share his story of how he established his level of competency. And he'll also lay out options for us to consider how we can achieve the level of confidence in implant dentistry and that we want, so we can start developing our skills immediately. And what I'll do, if you're okay with it, Dr. Diana, I'll post the link for your course in the chat box. So without further ado, it's my pleasure to introduce Dr. Stephen Diana.
Thanks, Jake. I'm going to see if I can get this figured out as far as sharing my screen goes. So let me know when you get my screen up and running. Slideshow. All right. Are we? I don't think we're there yet, are we?
No, you just have to hit the share screen button, the green one on the bottom.
I know, I did that. Give me 2 seconds and I will get this. So hit the share screen button. Now, I wanted to see.
And you just have to click on your keynote presentation.
Share. No, but then I wanted to go up here and you got to give me 1 second.
We see your screen now, Steve.
You see my whole screen?
Correct.
Yeah,
so if you go ahead and play it, you should be good.
Yeah, give me 2 seconds because that's not what I want to show you. I want to see my notes. So I'm going to stop sharing. I'm going to share with you. I'm going to click my keynote. I'm going to go back into this. I'm going to say play. I'm old guy, eh? Share. Sorry, guys. Okay, so now what are you seeing?
Just your pretty face, Steve.
Thanks. How about that?
Still just that.
It's telling me to restart my audio sharing application. Why is it telling me to do that? Are you seeing my screen now?
I just see your video. I don't see your presentation.
All right, sorry. We did this once before and I got it and now I'm not. So, basic, there, share. See me now?
Yeah, you're good to go now.
Good to go?
Yes, sir.
So what do you see? My screen there says educational pathways for the general dentist?
Yes, sir.
Perfect. So thanks again to everybody for the invitation and for inviting me back into this program. It's been an amazing program even for myself to log into. I want to see my thumbnail. There we are. So hats off to you, Sham, and the group for putting together an amazing group of lectures and at the last minute to put this together for these new grads that have been thrown into an interesting time in dentistry. I think it's a pretty amazing lineup of speakers. I'm excited to kind of give my 2 cents on my thoughts on how people can kind of proceed with engaging themselves in the concept of implant dentistry. As Jake said, I've got 20 years of experience placing implants and I think I do things fairly well, and I log into these lectures and I'm humbled by a lot of what I see by a lot of our colleagues. I'm humbled by it, but I'm also inspired by it because when you see what people are doing out there, you know, every day we operate in our own little practice and we do our thing, but we don't really see what other people are doing. And when we see what other people are doing, it's very, you should take it as inspirational. Sometimes when I see what other people do, you kind of beat yourself up and think maybe you're not doing things as well as other people are, but maybe the attitude should be more that it just kind of inspires you to want to be as good as what you see out there. So there's different philosophies on how people can engage in getting their implant education. And as new grads, it's difficult because you don't really know where to start. There's a lot of people that are canvassing for your time and for your money. And you've got to make some choices on how you can actually proceed in a smart way that will get you to where I think that you want to be. We all want to be at different places, and you need to make that decision for yourself. So you need to decide if you want to be somebody who places implants, somebody who restores implants, or somebody who wants to do both, place and restore implants. And obviously the pathways will be different depending on which way you want to go. So when I graduated in '97, there weren't a lot of options out there. There were not the whole plethora of courses that were available as there are now. There wasn't as much of a business of the educational side of things, and you had to kind of pick. You had to formulate your own pathway as far as how you were going to get yourself to where you wanted to be. So I'll kind of compare and contrast a couple of different concepts. I'm not going to brand anything. I'm not going to give you specific directions to any specific courses. I'm just going to give you concepts to think about, and I'd like you to kind of take those concepts and do what you will with them. So we're all different personalities. We all have different motivations. We all have different ambitions. You know that from looking around your classroom of students that you just graduated with. You're not all the same. And so you need to find a path that works for you and run with it. So as Jake had mentioned, I appreciate the compliments, Jake, on that nice note about having taken the course. When Jake came into the course, you could see right away that he was a pretty confident, driven person. And I'll tell you where the advantage I feel like I have in my position is, having done what I've done for 20 years, I've also had 12 years of people coming through my office and seeing every different dentist out there. I've seen the new grads that have just come out, and I've seen people who have had 20 years plus of experience. And you see how people are, and you get a different feel for the way clinicians' understanding of implant dentistry is. Some people have a great understanding of it, and then the second they go to work on a patient, they can't translate that to an action. Some people don't have a great understanding of it, yet have a great hand. So it's a matter of finding out who you are and working on the parts that are deficient. So what I'd like people to remember when it comes to implant dentistry is this slide. And at the end of the day, the reality is some things do last forever. And when you do your dentistry, especially with implant dentistry, you put that implant in and it integrates. It's there, and you're going to look at that forever. So you better make sure that it's in a position that you're happy with, and that you are considering everything you need to consider in advance of putting that implant in place. Without mentioning names, I watched some various conversations and discussions that happened between different doctors over some of these forums. And it's interesting to see that we all kind of do have our own little thoughts and tweaks about it. And I did hear the comment the other day about the fact that, success isn't defined by integration. And I agree with that 100%. So just because your implant integrates does not make for a successful implant. A successful implant is one that integrates, one that is aesthetic, one that meets the patient's needs, one that has longevity, one that is comfortable. There's so many variables to define success. So it's not just a matter of saying, I put the screw in and it worked. So you have to remember that when you put that implant in, hopefully it's there forever. When it comes to dentistry, there's lots of things that we do, and some things we don't do perfectly. So we might do restorations out of overhangs. We might do restorations with open contacts. We might do crowns with open margins. And the reality is, with those types of dentistry, you can usually fix them. And the fixing doesn't come without an expense. It comes with an expense of time. It comes with a monetary expense of sometimes redoing crowns that you have to pay for. And most importantly, it comes down to the patient having to go through another procedure because of a deficiency that, quite frankly, we created. So there are some things that have consequences, but usually you can fix them and make them go away with minimal consequence, if you will. I'm going to say the one exception to that so far with general dentistry has to do with endo. And when you see separated files, a separated file may actually compromise the outcome for that tooth. So with a separated file, that may or may not lead to the eventual tooth loss. So that's why when you start to look at trends in dentistry, and again, having been out for 23 years now, and you look at what happens over the years, things happen for a reason. So insurance companies, some insurance companies will actually not pay for a general practitioner to do an endo on a patient. They will be required to go to a specialist to have that root canal done. And that's not done for a reason. That's done because economically insurance companies understand that certain levels of skill sets are required for certain procedures to minimize risk. And so they've already established that from a monetary point of view. Now, that's not to say your patient can't have the root canal done in your office, but there's some data to substantiate the fact that the prognosis is going to be better if it's done by a specialist. So I'm a huge advocate for encouraging general practitioners to educate themselves and develop a level of competency that they can provide treatment to their patients at a really high level. But we have to respect the fact that our specialist colleagues have put some time and efforts into their education, and they just do things that maybe you and I will never do. Now, that being said, I know Steve just mentioned, and by the way, Steve, I thought your lecture was fantastic. And like yourself, I had to kind of revamp this talk because so much of the material has been covered by so many other speakers. But, Steve said, there's nothing ashamed about knowing where your limitations are right now, and it takes time to get to where you want to be. So you can appreciate that as a new grad, you're coming out with a certain level of education, and your specialist colleagues are putting some additional time into education. Now, granted, it might be 2 years or 4 years or 5 years, whatever it is, but they are getting that education that you didn't have. And then they're going to go straight into a practice where the focus and concentration on their practice is going to be specifically, if it's perio or surgery, it's going to have a high volume of implant dentistry. You as a general practitioner are going to have a spread out experience level of endo and restorative and pedo and implant dentistry. It just won't be as saturated. So you can get to a very high level of competency. It's just that it's going to take you longer because you're just not going to have the volume of patients that your specialist colleagues will. So again, remember that there's some things that you can fix and some things that you can't fix. And we're going to start straight up by me showing you a case that I did. I mean, not every case is perfect, right? I'm not going to tell you every one of my implants has worked. I don't have a 100% success rate. I don't have every case looking like it's $1 million, and I've made mistakes. This is a case that I did that I was so excited about the augmentation that I did. It was a young patient where we did a pretty significant block augmentation, and going into the implant placement afterwards, I erred. The implants are too close together, and we've got a bit of an aesthetic disaster on our hands. This is not a great outcome. This is a terrible outcome, but I'm not going to show you all my cases that are just wonderful. Most of my slides actually are not going to be very case driven. I'm not trying to teach you implant dentistry today. I'm going to try and teach you the thought process of how I'd like you to put together your educational program. But I am going to show you some of our cases over the years to show you some things that are good and some things that aren't very good. But that lasts forever. How do you fix this? These are the things that you need to learn as time goes on about how do you fix some of the problems that you probably will create. I have a couple of options here. I'm not going to go into them too much, but I could bury an implant and cantilever a prosthetic there, or I'd have to explant the implant altogether and start all over again. Those are really the only two choices. But the point is, we want to get you to the level before you start this kind of treatment so that you don't make these kinds of mistakes. But we all make these mistakes. So where do we start? So if we have a mostly Ontario-based audience here, the bottom line is the college has printed guidelines to tell you a little bit about where you need to start with respect to your educational experience so that you meet the requirements that they're going to hold you to. Now, when I first read these, and we all have access to these, I was a little critical of them, but now that I read them again, they're worded very well. And I think there's a lot of little key things in there that do make sense. So if we read that one right there, it says the level of complexity of the cases dentists elect to undertake should reflect the commensurate level of training and courses they have successfully completed and competency and experience they have acquired. So it's not one decision here. You need to have a certain level of training and courses, which they're going to define in a moment, but you also have to have some competency and experience. This all comes with time. This doesn't happen by taking one course. This all happens through a combination of time and experience. And I like the idea that they say that you have to have a certain level of competency, just because you completed the course, no offense, doesn't mean that you're competent. So you need to make those decisions on where you feel that you have the competency to provide that kind of care to your patients. It says dentists who provide both phases of treatment, so surgical and prosthetic, you need 70 hours of education before you can start. If you limit your practice to one or the other, then you need 35 hours of that discipline. So if you're going to do only prosthetics, you need 35 hours of prosthetics, but you also need some surgical training. That's 14 hours of surgical training. There's a reason for that, because they're not independent. Understanding the surgical placement of the implant depends on a prosthetic knowledge, and understanding the prosthetic options understands what the surgical capabilities are and what options can actually be provided for the patient. So you need to have both prosthetic and surgical training. It says here, dentists who provide the surgical phase of complex dental implant treatment should have been mentored by a suitably competent and experienced individual in an appropriately structured training program. I like that. The idea of mentorship is huge, because I'll tell you straight up that the reality is everybody who develops competency with implant dentistry gets it through their clinical experiences. It's not through your textbooks. You're all smart, capable, competent people. That's why you gotten to where you've gotten, but it doesn't mean that your clinical skills are going to reflect what you understand. Some things you just can't teach, and that's okay. You know, some people have a certain dexterity and some people don't, and that's okay. It doesn't mean, I find that there's a lot of dentists that feel pressured to do things because their colleagues are doing it. It's almost like if you're not doing it, then, and someone else is, that you need to do it. And that's not the case. You know, you don't need to do that. You will find your niche in your practice that is your thing, and you'll go with it. So for some people, it's aesthetic work and it's veneers and it's bonding direct bonding cases. Some people it's endo, some people it's implants. You can't master it all, in my opinion. So the college goes on to further define the fact that really where you need to start with your cases are going to be with straightforward cases as opposed to a complex case. And when we break down the criteria under the straightforward cases, they basically are saying that you can do single teeth in the non-aesthetic zone where you don't need to do any soft tissue or hard tissue grafting, and you're not changing the occlusal scheme of the patient. And Steve mentioned that in his lecture just prior to mine, where he said that that patient had if you're changing their vertical and changing their TMJ position, then that's not where you start. We're not trying to add too many layers to the onion here. We're just trying to start off with the basics. So you want single teeth, non-aesthetic, no need for grafting. It's not going to be very many of your cases, straight up. Most implant cases need one of those variables to be compromised. They're going to be multiple units, or they're going to be in the aesthetic area. And just because it's a bicuspid doesn't mean it's not in the aesthetic area, because if they have a high smile line, then that's going to be an aesthetic implant placement. But the reality is the majority of your cases are going to be single, straightforward cases, posterior. Now, we've all been seeing this curve on the television and the news all the time, and we're all wanting the curve to flatten. That's the whole goal, so we can get back to work. But I'm going to propose to you that the curve that you're going to be thinking about with implant education is going to be more like this. You're not going to start out with a lot of cases in your practice. You're going to have very few implants in your practice. You're going to have a slow growth to your implant practice, and you're going to use that time to educate yourself. And then when you get to that first plateau, you're going to get a little bit of confidence. You're going to do a few more implants. And then as you get more experience, you're going to go into more education. You're going to ramp up again, and then you're going to start doing additional, more complex cases. And then once again, you're going to build on that education, and you're going to keep building on what you know based on your experience level to actually get to a point that you're doing all the cases that I'm doing 23 years later. You know, we didn't start doing these straight out of the gate. We built on our education with our experience. This is the kind of case you're going to start with. Single, posterior, implant, non-aesthetic zone. Is that a case that carries no risk? Well, of course not. Every case carries risk, and every case is equally important. But that's what you're starting with, a single posterior molar, where really your primary risk has to do with the nerve positioning, and that comes down to your diagnostics and your case assessment. But that's the kind of thing that people should be starting with and doing day in and day out. And that's a pretty common scenario to be presented with. I find that the majority of cases that we're dealing with are going to be upper and lower sixes. It makes sense. Why does it make sense? The longest tooth that's been in the mouth since it comes in on average age 6. Most common tooth, I think, for endo treatment, most common tooth for GPs to miss, the MB2 in the upper. And so retreatments and failures are common. So tooth loss is a problem. Somebody made the conversation, I think it was yesterday with Azim, about the money tooth, about how much time and effort is put into a tooth with respect to restorative, then endo retreat, crown extraction, and then implant. So an upper 6, a lower 6 is a very common scenario to start with. When we teach in our program, as Steve mentioned earlier, I was glad to see that as well, that this concept of records are huge. Everybody needs to start with records. You need to start with photos. You need to have good radiography, and you need to make a decision on whether or not you want to utilize cone beam technology or not. This is not my case. This is a case that was presented to me by one of the people that do our mentorship program. And this is what we ask for. We ask for people to acquire records and start to go through the thought process so that they can actually come up with a plan prior to engaging me in conversation about what they're going to do. You know, your mentor is there to help you along, not to make all the decisions for you. So people have to start by acquiring their records and coming up with a treatment plan, cone beam or not. And then they lay out a plan. And we don't have to worry about reading the slide, but basically what they've done is they've gone through and they've laid out a strategy so they know where they're going to end up at the end. And they, much like what Steve had mentioned earlier about the COIS formulation, every case needs to have a plan and a strategy. A plan, and Azim mentioned yesterday, plan 1, plan 2, and plan 3. You need to have the whole case thought through before you even start. So we lay out a problem set, we lay out a plan. Now, for newbies, this is where you start. You start with the basics. When you started driving your car, you didn't go on the track right away. You started with the basics. You read the manual, and then you went out with an instructor who was your mentor, and your instructor showed you what to do. And then you gradually, with time, become more experienced, and then you progress on to becoming a little bit older. And you can become that person who's 19 years old now, and you're so experienced, and you can go 300 kilometers an hour on the QW. I don't know if everybody saw that in the news, but that was quite impressive. So we're not starting at 308 kilometers. You wait till you get to my age, then you can do 308 kilometers an hour. So you start out with the driver's handbook. So these are the kinds of cases that we progress to. This is not where you start. So this is a case with a single central that was removed. The 1-1 was removed. It was replaced with an implant, and we end up with, in my opinion, a fairly aesthetic result. Now, that's not where you're starting. That's where you're ending up, because there's a lot of components to this case which define success for me. In addition to the implant, it's got to do with the aesthetics of the ceramic, the papillas, the zeniths. Having the whole case come together like this isn't just by chance. It's understanding a lot of variables and being able to understand and control the variables so that you end up with a nice result. It just doesn't happen. This is what we want to see. We want to see beautiful, nice, soft tissue profiles around our implants, implants placed in the proper position. The tissue has been respected and manipulated properly. And here we go. I'll show you my first case. So this is the first case I ever did 22 years ago. If you look in the lower left quadrant, there was implant number 35 and 36, and then an implant in the 24 that was done subsequently. When we look at that implant, I'll tell you the quick history of it, but basically I had placed that implant having only ever done my GPR at Toronto General Hospital. I'd never taken an implant course. I read books, I watched surgeons at the hospital, and then I brought in the rep who walked me through it. The result ended up fairly well, but that's not how I encourage you to do things these days. But like I said, times were a little different back then, and am I proud of that? I'm proud of the result, but I'm not proud of the fact that that's the kind of level of education that we had prior to doing something like this. Nice result. That bite wing is it's almost 20 years later after the fact, and you see that things have behaved fairly well. So when it comes to implant dentistry education, the reality is if you are somebody who wants to do it all, you want to place, you want to restore, understand what we're talking about here. You know, the talks that you've seen on this forum have been so fantastic, and they're so comprehensive, and the people that are giving you those talks are really experts in this field. Either they are specialists of perio and prosto, you have a surgeon speak as well, or the people who have done it by time, and they've earned the gray hair over time, and they've done the cases and they've made the mistakes. So learn from the people that have paid their dues, but understand the fact that there's a lot to this. Now, with respect to implant dentistry, you know, it all starts with diagnostics. You got to be really good at interpreting your images. Cone beam now is a standard of care. You are lucky to step into a realm where you have this idea of digital planning, and surgical guides are an option. But we have to do treatment planning with our patients. Steve just did a great presentation on treatment planning and gave you some guidance on a bit of a checklist. And checklists, I'm a huge fan of checklists, because checklists basically minimize your mistakes. Because what happens is, as you become more experienced, you become more confident. As you become more confident, you make less frequent mistakes, but you still make mistakes because you become a little bit complacent, and you start to forget some of the steps that you go through. So having a checklist, and I was kind of impressed to see that someone of Steve's experience and skill is still making sure that he routinely goes through a checklist on every single case. That way he doesn't overlook things and doesn't make any kind of casual mistakes. So this concept of treatment planning, the yellow Lego piece, to me is huge. And that really is the part that comes with experience. The diagnostic part is something that you guys can spend all kinds of time right now, especially since we're not working. There's all kinds of online education that will be very comprehensive with respect to diagnostics. Treatment planning is going to come through observation and through time. Surgical skills are going to come with time. I mean, you just can't have that right away. And I was really pleased to hear Pierre yesterday talk about the fact that he really feels, and I do too, that a lot of new grads just need to become good at taking teeth out. You just got to be able to get teeth out. You got to get your surgical skills need to be there before you go on to the next layer of treatment, which to me, implant dentistry is just that much more sophisticated. So you got to get your basic skills down. I get very frustrated when I have people coming into the clinic here who want to do all kinds of comprehensive implant dentistry, but it takes them half an hour to suture a 1-quadrant flap. You know, if your suturing skills aren't there yet, you're not ready yet, and that's okay. But you need to develop those skills before you get too sophisticated with what you're providing. So we need diagnostic skills, we need treatment planning skills, we need oral surgical skills, we need restorative understanding. We've got prosthetic things to think about, you know, our occlusal schemes, our biomechanics, our AP spread. We're going to talk about that a little bit here going forward. Put it all together and you end up with a beautiful tooth. So you too can do that. So when we talk about radiology, you know, panoramic interpretation, don't undermine it. I mean, being newer grads, you probably know more about interpreting panorexes than some of the more senior people, because you've been examined on some of the anatomy that you see in panorexes that maybe we don't look for as much as you will. But stay on top of your panoramic interpretation because it's important. Cone beam interpretation is going to be something that's going to be, if you haven't done it already in school, I don't know what they expose you to, but it's going to be something that you should work into your understanding. If you have any intention of getting your cone beam at any point, which I think you will as new grads, my suggestion would be put yourself in queue for getting your cone beam certification. So that's, you need in Ontario to take a course to be licensed to interpret your cone beams. And it's currently, my understanding, I'm no expert in this, my understanding is it's at Western and at U of T, and the courses are not held very often and they fill up really quickly. It's kind of like getting your driver's license. Once you've got it, you've got it. So if you're going to need it at some point. So to me, I would, once you've got the economics to justify the tuition fees, I would put myself in queue for a cone beam certification course right away. Because if you go looking for them now, you may not get in until next year or the end of next year as it is anyways. So you might as well do it because you're going to need it. So I personally would sign up for a cone beam course almost right away. We saw a great talk by Christian Hall the other day on treatment planning, and he was showing the use of, I believe, the Nobel software for doing treatment planning. But there's all kinds of courses out there. I'll show you a quick little video in a moment about the use of Simplant software for treatment planning. But taking your cone beam data and putting it into software for doing your treatment planning will be a huge, valuable tool for you on understanding the options with respect to implant dentistry going forward. And on YouTube, there's all kinds of videos on digital treatment planning for implant dentistry on cone beams. But again, if you look at the lectures that have been put together through your dentistry academy here, they're fantastic. If you haven't seen it already, pull up Mr. Hall's lecture on cone beam interpretation and use of software and guide fabrication. And you got a fantastic starting point right there. How's my time, Shannon?
You're doing good, Steve. You still have 10, 15 minutes.
That's it. Okay, I'm gonna boogie.
We'll give you some more. There's nobody after you, so take your time.
All right, so I'm gonna show you, as a new grad, if you haven't seen this already, let me just show you a quick little video which shows you the value of cone beam interpretation. This is a case that I did guided, and I did it guided because if you look at the cone beam, you'll see that the nerve actually traverses the crest of the ridge for quite a distance. And so doing my traditional flap in this case would pose some risk. I think if you look at the imaging, you'll appreciate too that there's very minimal bone here to place our implants. But when you watch Mr. Hall's lecture, you'll see the fact that you're able, with this use of this digital planning, to marry your prosthetic and your radiographic data to come up with an ideal treatment plan for your patient prior to surgerizing them. So that's a huge tool. And you'll see that we're able to actually go through the entire case. I'm just going to fast forward it a bit. And you see we're able to go through the entire case and prosthetically place the implants and angle the implants and go through our whole visual video game, if you will, prior to actually committing the patient to a treatment plan. So it helps you kind of understand what the prosthetic options are and the surgical options for the patient, and work a case through in its entirety before you even start. So that's just a quick little demo, which again, Mr. Hall showed a great presentation on that. Now, so maybe I'll just defer you to look up that one in the sake of time. The one that I like to spend a bit of time on, though, is this piece, is the treatment planning. And again, we just watched Steve's lecture, which I thought was fantastic, and he kind of went on the fly there to create a great presentation and incorporating the COIS analysis sheet. But at the end of the day, the reality is, with respect to treatment planning, you're going to talk to different dentists, and different dentists will treat and plan cases in different ways. You might be a big locator fan for overdentures. You may not be. You might be more of a conus overdenture case or a bar overdenture doctor. So there are different options. And the important thing is not to say that one is right and one is wrong, but it's a matter of finding out what the best option for your patient is. What meets your patient expectations? And again, that's why I thought that was so important when Steve highlighted the fact that comment about what the patient's expectation was should almost be the first thing on the page, because ultimately that's what's going to define success, is if your patient is satisfied with the treatment that you provided. So understanding what options are available is your job, and then presenting those options to the patient is also your job. And that's something that's kind of hard to teach. That's a people skill. So, you can get softwares and you can get models and you can do all that, but in my experience, our case acceptance is so high because I think you just have to talk to people like a real person. Don't put yourself on here and your patient here and talk to them on a different level. Talk to them as a person and understand what's important to them, and be sensitive to some of their limitations, often those being financial. And then coming up with a sequence of treatment is going to be something that you have to outlay. At what stage do you do things? Can you do an immediate implant? Can you do an immediate crown on top of an implant? Those are decisions that you need to make with the experience and time. So just for sake of interest, a couple of quick cases that we're not going to go through in entirety. But when we look at this as a dentist, even as a new grad, you should look at this and things should jump out to you right away. Patients missing teeth in the second quadrant from 2.2 to 2.5. And if you look at the patient, they're heavily restored, they're abruxer, they're overclosed, there's lots of porcelain work there. You start to see a bit of exostosis, and that sometimes goes hand in hand with people that are clenchers and bruxers. So the occlusal loads are heavy, fractured teeth that were endodontically treated. How many implants are you going to place? Are you going to place 2? Are you going to place 3? Are you going to place 4? And again, you talk to different doctors and people will give you different opinions on that. And my job today is not to teach you what the right option is. My job is to try and tell you what things do you need to think about and what kind of courses do you need to take to have that understanding about what options are out there. So in my case, I placed 3 implants, 22, 23, and 25 with a pontic in the middle. We did Atlantis abutments with a cemented bridge. And again, what kind of bridge are we doing? Are we doing a PFM? Are we doing a zirconium bridge? Are we doing screw retained? Are we doing cemented? These are all decisions that you need to make, and you need to come up with a strategy to educate yourself so that you know how to make those decisions. A case like this, would you keep that single bicuspid in the middle? Would you extract it? Would you make it a 3-unit bridge on the 2 implants? Is there value in keeping the 45? What's the prognosis for the 45? These are things, again, that come with experience, but they're not going to be just out of a textbook. So these are things you need to personally experience and see with your patients. And those are the things that will help you make these decisions. Lower incisor. One of the presentations talked about the fact that there wasn't enough room for 2 implants. I think it was Mr. Hall's presentation on the planning, and showing that the value on the software showed that he was not able to place 2 implants for lower incisors. So then the decision was, let's place a single implant, and what will that look like? You know, so this is what it looks like. It's a fairly reasonable result. Is that satisfy patient expectations? Well, you should be able to tell them what it's going to look like before you even start. And that's all in the case presentation. And how do you develop a library of material to show your patients in advance? Take your photos and document your cases. Use of implants and a little bit of orthodontic work. Single implant, the posterior teeth have come forward a little bit. We can actually use the implant as an abutment, and we can use it as anchorage to distalize the segment as opposed to bracketing the whole arch. So incorporating implants into orthodontic treatment plans is something that we think about. So treatment planning is complex, and I think Steve did a great job to kind of highlight that in 1 hour. He used a great example of that one case and walked us through it. But I think the take-home message for new grads is not to be able to take from what he said and treatment plan a full arch case. It's more appreciate the thought process that he's going through to put all those considerations together and come up with a plan. Now, someone experienced like himself is able to do that, quite frankly, in his head before he even starts itemizing all those things on the checklist. But having that checklist helps minimize the number of things that you might overlook and the mistakes that you make. So now we've got some radiology, we've got some treatment planning and diagnostics. We present it to the patient, we go forward with doing our implants. So now in the operatory, we need surgical skills. So how do you develop surgical skills? Tina and Nahid both gave great presentations on all kinds of things, from flap design and suturing techniques, suturing materials, graft materials. And then, quite frankly, and no insult to new grads, you understand this stuff and you've taught this stuff, you've been taught this stuff and you get it, but you haven't seen it happen in your hands. And I think he made the comment about the fact that there's nothing like opening up a flap after you've done a bone graft and seeing all that new bone that you grew. It's a very satisfying thing. And that can only happen by doing it. It can't happen by being shown it. You've got to experience it yourself. So you need courses on oral surgery. Are you comfortable doing a flap like that? Or are you not? Some people aren't. Are you comfortable identifying the mental nerve? Is that going to be something that's going to intimidate you? If that's going to intimidate you, then doing bigger cases is not going to be something for you. Or do we want to approach the whole idea of flapless surgery, which I'm not a fan of? Or do we want to engage ourselves in guided surgery? These are decisions that you need to make. So you need to understand the differences between the different options and identify when you would use what type of approach. Again, would you be comfortable doing something like that? You need to be able to do something like that if you want to utilize guides. If you want to do a big case with an all-on-X, like Steve showed you previously, you notice this flap. That was a full arch flap with a big guide screwed to it. So you can't just hide behind the idea of saying that a guide is going to be my savior. You need to be able to be comfortable with opening up significant flaps to utilize the technology that you want to use to make the implant placement side of it easier. So we need some surgical skills and understanding little nuances. So even look at this. We look at this case and watch how such a little thing can make such a big difference to that smile. Little tiny details are what make the case successful. So a little bit of gingival contouring on that little bit of hyperplastic tissue makes a completely different appearance to that patient's smile. And that's just an example of using a little bit of cautery or laser or however you want to do it. But the point of the slide was to show you the fact that a little tiny detail can change the whole presentation of the case. And you miss one of those details and the whole case is compromised. Like the tattoo guy, it lasts forever. We need to understand materials. So when we take our impressions and we send stuff off to the lab, what are you ordering? Are you ordering a PFM? Are you ordering zirconia? Do you want screw retained? Do you want cemented? Those are decisions that need to be made. So we need courses on understanding materials. Again, if you talk to dentists of my age, a lot of us haven't taken courses on ceramics, for example, in maybe other people have. I haven't taken a course in ceramics. So when you take an impression and you send it off for veneers and you're prescribing, what are you asking your lab? Make me 6 veneers, or are you getting down to the nitty gritty and defining what ceramic you want the lab to use and how you want it used? Understanding those little details is important. And you've had some great talks on here. So you got a whole library of talks on the Dentistry Academy YouTube site that are just fantastic, that each one of those talks kind of covers a component like this. When we take impressions, do you need to go open tray, closed tray? Are you scanning now? So you guys are entering an era where scanners are more important. And Dr. Sumner, who's a classmate of mine, is a huge advocate of going digital and doing everything with a scanner nowadays as opposed to taking impressions. And I have to agree. I think that's the way to go these days. Are we doing this again? Are we doing cement retained or screw retained? I like this slide. If you look up in the middle implant here, look at the amount of cement that's down along that implant and look at the consequence of what's happened there. So now these are real life cases, and these are real life decisions that you as a clinician, starting on Monday in your practice, hopefully when we're back to work, you see this walk into the office. If you're an implant dentist, you need to look at that and be able to know what the options are for that patient and how should that case be managed. And you can't do that yet if you just have everything as far as a textbook educational experience. You need to have clinical experience with these to know how to manage cases like this. When I look at this slide, and this is not, I didn't place these implants and I didn't restore these implants, but when I look at this slide, things go through my mind. Why did the surgeon decide on 3 different implant designs for 3 different consecutive implants as opposed to any kind of consistency there? I also look at things like the casting now. And we saw that great lecture by Goff. I'm sorry, I don't know your name.
Goff.
Goff. It was a phenomenal lecture. And if you see, this is why until you experience things over time and as a clinician, you won't pick up on some of the little things that are said in some of these lectures. But someone like with my experience in my time, he actually commented on how he analyzed his casting on a framework prior to going into the lab for ceramic to make sure that the casting was adequate in all the right spots to support the porcelain so that he would minimize his risk of fractures. And I can almost guarantee you 90% of dentists out there don't do that, including myself. So we're not taught to appreciate the amount of thickness that we're taught it, but we forget it. The amount of thickness that we need to support our porcelain to minimize fracture. But that's what a prosthodontist does. So appreciate the fact that a prosthodontist, that's his passion. He understands that kind of stuff and he looks for that stuff. But now if you're trying to become that general practitioner that does the radiology, the surgery, the restorative, and the prosthetics, how can we take everything to the same level that our colleagues do? You can with time, but it's not going to happen straight out of the gate, and that's okay. But you look at the casting on each of those 3 consecutive crowns, and it's all different. And so which one's most appropriate, which one's not? Those are the things that you need to start analyzing and look at. With our prosthetics, again, things we need to learn about: occlusal schemes, biomechanics, AP spreads, and cantilevers. Can you do cantilevers on implants? Can't you? Can I do a single implant on an upper cuspid and make solid canine function on that implant? And if so, how big should that implant be to tolerate that function? Those are all the little things that you need to be able to put together that you can't put together until you've got all these little pieces of understanding through either education or experience, or in my opinion, both. It can't happen just through education. It has to happen through experience. So you need to put it all together. You need to get these components and have a good understanding of them all. You need to compile them all so that you're not overlooking anything. So understand again that we have specialists that are diagnosticians. We have radiologists. We have surgeons. We have prosthodontists. We have labs that are specialists. You need to understand it to a clinical level and put it all together so you're providing a quality of care that's appropriate for your patients. So how can you do this? I mean, you're going to look for courses, and that's the purpose of the talk. So we'll get to that. And you're going to look for courses, and then you're going to be a perpetual learner. And I'm a big fan of Dental XP, and that's the only one slide I'm putting up that's any kind of promotional thing. I don't know why, just because I like it. I know Spears has the same kind of idea. And you can find nowadays, we're very fortunate to have this online abundance of education, which basically gives you unlimited access to articles and webinars and continuing education programs continuously. So there's no excuse not to go in searching for the material that you're looking for, and it's all out there. So you put together your own package. So now going forward, you put together your own course. You decide, do you want to put together a course where basically it's all bundled for you, or do you want to put it together and piecemeal it? So when I say bundled together, and again, without naming names of courses, there's courses out there that will offer you a big continuum, and you can have it all provided in one nice environment, or you can put it together yourself. And that's quite frankly what I did. So 23 years ago when I started, I didn't have the option for the big bundle course. So basically I took courses on radiology, I took courses on surgery, I took courses on treatment planning, I took courses on sinus lifts, I took courses on block grafts. So I put it together, and I learned from different speakers. Now you can either just take a one lump package, or you can put it all together yourself. So where do you start? First things first, I say you take a course that gets you up and running. You need your 70 hours. Okay, that's what you need. We're gonna come back to that. So that slide was out of queue. You need to decide, if your goal is to restore implants only, you need 35 hours of restorative, but you need 14 hours of surgery. That's the college guidelines. If you want to place, you need 14 hours of restorative and 35 hours of surgery. If you want to do both, you need 70 hours. So bottom line is, if anybody wants to be surgical, you need a minimum of 70 hours of education. And again, where do you start? Pick a course that gets you up and running with that 70 hours. Analyze that course, and I look at and the breakdown for the hours. What kind of content is in there, and does it fit the curriculum of what you kind of want to know? And I'll tell you now, most of the courses will just basically follow the college guidelines about the material that should be covered, and we all kind of cover a lot of the same material. But analyze the course. How many days is the program, and how far is it spread out throughout the year? So is it condensed into a short period of time, or does it give you some education and then bring you back, and then some education then bring you back, and you're coming in over 5 or 10 months? I think you want this to be in a very short period of time, because goal number one is to get your 70 hours so that you can actually technically start, according to college guidelines, start getting your hands on implants. So you just want to get the good foundation that puts it all together in a very short period of time. And you need a live patient component. I don't think there's enough to basically just place an implant on a pig mandible or on a typodont. You need to have a live patient component. So you need the option for you to place implants on a live patient, and for you to see live patient surgeries as well. Because again, it all comes down to clinical. It's not going to be a matter of being book smart. It's going to be a matter of having some good clinical experience. And anybody that's been through the program here, and I think Jake will chime in later to say, every case is different. The concepts are the same, but every single case that we see as a group has something different about it. So having a live component is absolute. And then I also think class size is going to be an important thing. You want to be in a big auditorium like you were in dental school and sit in the back of the class and play cards with your buddy like I did? Or do you want to have a little bit of more interaction with the person who is kind of teaching you? So those are variables that I think that are really important for that first course that you're going to take, just to get you up and running. Now, once you get up and running, the next most important part to your education, to me, this is the crucial portion of it, and I think my classmate Mia and Queck talked about this in his lecture about having a mentor. I think a mentor is crucial to developing your implant experience, because again, every case is different. You need somebody that you can present your cases to and discuss them with in advance. You need somebody that you can do your cases chairside with. And somebody that you can present your problems to, and who can kind of help you out, and have that mentor that's going to give you that guidance, as opposed to having to look things up in your notes, because it's not the same. How do you pick your mentor? To me, I think you need to interview that person, and you need to select somebody that's conducive to your learning style. So as I said at the beginning, you look around your class, you're all different. So you're not all going to jive with the same person. You need to find somebody that's going to be following the philosophy that you want to subscribe to, and you want to pick somebody that you're going to be able to work with, because it is a bit of a long-standing relationship. I think you need to document all your cases with photography. If you look at your cases and you can go back on the photos and you can analyze them, you look back on things and you learn from them. You need to start with non-aesthetic cases, and that mentor needs to be geographically convenient for you. Meaning, I'm flattered when people want to come and have me as a mentor, but if you're coming in from the Ottawa area, it's not going to be very easy for you to be bringing your patients out to our clinic and doing cases together. I've had it. I've had people fly in and do mentorships here with their family members as well, but it's not convenient. So you need to find somebody that's going to be local to you. And sometimes that can even be your specialist colleagues. I mean, if you're sending cases to your specialist colleagues, I think a lot of them would be receptive to people that want to learn. Now they're running a business too, and they have their own patient load. They don't have tons of time, but I can't imagine people not being receptive to colleagues that they like to work with in having good conversations that are in the best interest of patients. So, engage your specialist colleagues, and sometimes they'll let you come in and watch surgeries and just sit chairside with people. And then most importantly to me is respect that curve. Don't try and do things too fast, too substantially and too fast. You just will be unhappy with yourself if you run into problems, and that'll bring you down. So do things that are predictable. After you've had some clinical experience, now you can take in some additional courses and kind of hone your skills. You'll find where you're deficient. Maybe you have a problem with flaps. Maybe you have a problem with suturing. Maybe you want some more understanding of the prosthetic options in the all-on-4. You're not going to start with all-on-4, all-on-6. You're going to start with single cases. So get those skills kind of honed so that you've got everything is second nature, and then you can build on it. So when we do our courses here, we have an introductory course and a more advanced course. I don't let people into the more advanced course until they've done a certain number of cases, because at that point, we can't be talking about things like what's this burr for and what's that burr for and how do I suture this or where do I start with a flap. You have to have a certain understanding of some basic skills before you go on to the next level so that you'll get the most out of it. So you start basic, you get your 70 hours, you get a mentor, you work on your cases over time, and that's gonna be different for everybody. Some people might get through 10 cases in a year. Some people might get through 100 cases in a year. So the rate that you grow will be proportional to what you have in your practice. And then, like I say, as time goes on, there will always be courses, even for me, there are courses that you'll always be taking to kind of take your clinical experience to that next level. Power of photography is huge. You can take a picture and you can show that to a patient and they understand why they need a crown or why a tooth is cracked. So you need to take pictures. And again, I'm a very confident person with my implant practice, and I'm very encouraging of everybody out there to do the same. And sometimes I'm a little casual to think that, we're GPs and we're great and we can all do it, and we can. But I also forget the fact that all this gray hair has come in, and I've been doing this for a while. And we need to be mindful of our specialist colleagues out there. They're out there, and respect them for who they are and what they do. They've paid their time, and they've been seeing a surplus of patients, no offense, but relative to the average general practitioner, they've done more of it than we have in a shorter period of time. So they've got a skill set, and now we're trying to become all of them. We're trying to become a radiologist with our cone beams. We're trying to become a surgeon with our flaps and perio. And we're trying to become a prosthodontist by doing these big, elaborate prosthetics. So you need to be respectful of our colleagues, and they're not there to fix your problems. They're there to help us, and they're there to do the cases that are outside of our league. And I think when you have a patient sitting in front of you, the best piece of advice I can always give you is, if that person in the chair was your son, your daughter, your wife, yourself, would you be comfortable doing that treatment on that person? Or if that was you or your daughter, would you say, like, I'm not doing this one, I'm sending this to my specialist friend? If that's the answer, then you shouldn't do that case, period. I mean, at the end of the day, it's not about the money. It's not about doing it just because you want to. It's about making sure that the outcome for that patient is as ideal as it can be. And if you're not the person to do that, then you shouldn't do it. And I'm not saying that to discourage people from learning this. I just think you need to respect it. So this is not what I want to see from people. You don't want to be doing something like this. You want to be the person that's doing this. That's pretty straightforward. You need to be able to say, all right, I place implants and I'm an implant dentist. So now when I see something like this, how do you manage that? You need courses on managing complications and failures. You can't just place implants, watch things fail, and then send them off to your colleagues and say, well, this one's failing. Can you fix it for me now? It's not appropriate. So your specialists are not there to be dumped on and to pick up not the problems and the mistakes. These aren't mistakes per se. These are complications of things, but you need to be able to address them yourself. Now, that's not to say that you can't ask for help. Of course you can ask for help, but you can't be asking for your specialist to bail you out all the time. They're there to work with you and to work as a group. I'll finish off with, I think this is the last or the second last slide. This is my case, another one of my cases. It's an older case. It's my mistake. Implant is too close to the adjacent tooth, blew out the papilla on a young person. That's disaster. That's disaster. So that's a disaster that is impossible to fix, period. And I did it. So you don't want to be doing these things, and you want to understand how to minimize your risk there. And that's why I think going through that respectful process of that learning curve, I think is important. So again, some things last forever. So you have regrets. You know, I think this person might regret that. Now, I'm nothing against tattoos. I've got my share, and I like tattoos, but I'm going to say this guy may regret this year. So you don't want to be regretting things. Respect that curve. Appreciate that all the incredible lectures that you've seen on this platform have been presented by people that have a lot of experience. And so it's very exciting to want to be a part of that. And I think we all kind of want our colleagues to be part of it. But as long as you're representing the general practitioner market to our specialist colleagues in a mindful and respectful way, and taking your time to do the due diligence of educating yourself, and also taking your due diligence of doing your cases in an appropriate fashion. So again, not trying to give you a steer into any particular course. I just think you need to think about the criteria that are important to you, and pick the program that fits your philosophy the best way. So research them. Don't just sign up for them because you see it advertised in the price point. Research them. All right.
Awesome. Thank you so much for that, Steve. And yeah, I don't know if that was a good idea with all those tattoos, but to each their own, right? Before we go ahead and get started with the Q&A section with Steph, I'm going to just do a couple of housekeeping announcements. The first one is that tomorrow, May 20th at 11 a.m., we'll be welcoming Dr. Matt Morrison, who will be discussing evidence-based management of TMD, followed by the misadventures in oral surgery by Dr. Chris Finelli. So make sure that you guys tune in, dtacademy.ca, and as always, the password is track20, all caps. And I've seen both of the presentations. You guys are in for quite the treat tomorrow, and it's definitely a must-watch for both talks. So we're going to go ahead, pass things on over to Steph for the Q&A aspect.
Hi, Dr. Diana. Thank you for that talk. I've been lucky enough to take a course from Dr. Diana, and it's you know, something. He's very knowledgeable and very, very good at what he does. And me as a new grad, it was certainly very helpful in expanding my implant knowledge. So we just had a few questions, you know, through your talk, I was like, oh, I have a question about this, and then you'd cover it. So there weren't too many questions, but I'll start with the first one. Somebody asked, which cone beam machine do you recommend for a GP placing implants?
I'm not going to.
Okay.
That's a tough one. I mean, you know, getting involved with specific products and all that, you have to, that's tough, because you're engaging in an expensive purchase, and do your research on it. I mean, I've been a fan of the Sirona line of products because I do a lot of work with Sirona, and so keeping my product lines continuous within the office have been important. I think Dr. Sumner lectured about having his SL, which is what I have in the office, and having that marry with his prime scan really well. So if you're going to get involved with the purchase of a cone beam, I mean, I think there's a lot of variables that you want to look at in deciding which one you're going to buy. But with respect to digital, we all know that if you stay within a family, things have to be able to speak to each other, and you want that seamless kind of continuity of workflow. And so if you're going to be a Dentsply Sirona person with respect to your scanner and use a prime scan, then you'll want to consider the Dentsply Sirona cone beam as well. But if you've already got something else in the office, you'll want to make sure that those technologies integrate and work together well.
Okay, perfect. They also had asked, when should a GP who wants to place implants or does start buying a CBCT?
Yeah, that's another one. To me, I know Azim yesterday mentioned the fact that he really exponentially grew his implant volume in his office by having his cone beam in office. I haven't had mine long enough to comment on that, on how it's going to impact my case acceptance. My case acceptance is really high. I think it depends on where you are in your practice and where geographically you are. I think if you have access to somebody to do it for you at the moment, I would start with that. If you're, depends where you are. If you're starting a new practice and you're making a purchase anyway, I'm not going to tell you to buy a new Panorex and then later on buy a cone beam. You can also buy machines that are upgradable, so there are options in that respect. So if you're starting a new practice, you have the option to buy a Panorex machine, so a 2D machine that you can upgrade to 3D later. You do the math on that, I think it ends up costing you more in the long run. So that may or may not work out for you. If you've got no need to purchase anything at the moment, and you have access to a center that can do the imaging for you, again, going back to that Lego piece about the radiologist exists for a reason, why not delegate it for now? Because for the volume that you're going to do, it may not justify it. If you're only doing 10 to 15 implants a year, in my opinion, that's not going to justify purchasing a $100,000 machine. If you've got a guy around the corner who will do it, a guy or girl, sorry, who will do it for you and give you the report and have all the responsibility of it. So you got to pick, you know, you can't do it all at once. And so I don't think the purchase of a cone beam is necessarily something that you should do straight out of the gate.
Right.
And to add to that too, Steve, one of the other things that Dr. Queck always talks about is making sure that you can justify a good return on your investment. So by looking at this product, looking at how much it costs, you have to ask yourself, am I going to be able to pay it back in about 3 to 5 years? And if the answer to that is yes, then you could probably justify it from a monetary perspective. But as Dr. Diana said, that I just bought a CBCT and I've placed thousands of implants at this point. And I think, Steve, you're the same way as well. Because if you do have centers that are able to do it at a very high level, sometimes it's just easier to do it that way. But also remember too that a CBCT also has some significant advantages and bonuses when it comes to endo, wisdom teeth, orthodontics, bone grafting. So as long as you're able to justify using it in your practice, then it's definitely one of a few products that you can buy that will gain you a tremendous amount of a return on your investment.
And if I may, the one thing I'll add to that is, there's not a single thing I've ever purchased in my practice that I wanted to put in here and felt like I needed to use because of what it cost me. I want to push the button on that machine because I need it. And I think I'm not going to say people do it because I don't know. I just know what I do. I just know what I hear from the salespeople that are out in the workforce. That there are a group of people that will, and you can tell by when people are lecturing that sometimes people utilize technology because they've got it and they can push the button and they can bill for it. And it's always the wrong reason. So you have to look at what you need this for. And like Sham said there, you're going to use it for diagnosing cracked teeth and for AIDS, and you're going to use it for other reasons. But every practice is going to have its own need for that. And so you have to look at what kind of practice you have and what kind of dentistry you plan on doing, and then merge into it in a respectful way. And like you just said, like if you've got a center that's close to you enough, and if you're in the GTA of any way, there's lots of, everyone knows Canray, and I'm sure there's other places as well that can do the imaging for you that's very economical as well.
Okay, and another question here. Let me just see here. Sorry. They had asked what you would charge for. How much should a GP charge for a single implant if he does surgical and the restorative part?
That's $1 million question too. And I mean, so bottom line in my office, my implant fee is too low. So I've been between $3,000 and $3,500 for the implant and the crown combined. And that's but now you have to talk about what are you placing? So I'm placing brand name implants. I'm placing custom, Atlantis abutments, and I'm placing PFM or zirconium crowns. They're not all created equal. It depends on where you're buying things from and what you're paying for things. So it's a multi-layered question because and I've got 23 years of experience, and I've had people that take my course that have been out of school for a week who are sitting there saying, well, they're going to charge the same as I'm charging because that's what we do in this province. And that's true. And that's fine. But you have to set a fee that you're comfortable with. Now, I will quote one person that gave a lecture a long time ago, Dr. Barzilay, who's a prosthodontist, who's pretty well respected and an incredible lecturer as well, who, again, you take little things out of people's talks. And he talked about not underpricing what you do. Because what you don't realize is, until you experience it, is for every implant that you lose, it's going to cost you the next 3 or 4 to make that profit margin back on that implant. So don't undercut yourself. Don't do things too cheaply, because so if you're trying to say, oh, okay, well, look, that only took me 20 minutes and it all worked out so well, so I can reduce my fee on that, it's going to be a bad strategy. And I'll tell you why, because that's what I did. So it doesn't work out. So you got to be competitive. You got to know your marketplace. I think different neighborhoods are going to have different price points. And again, not to take away, I'm glad you brought that up actually, because not to take away from what our specialists do, but the reality is once we start involving all the specialists and everything, it gets very expensive for our patients. And so first and foremost, I know I can provide the treatment that I provide for my patient very comfortably and very confidently. And I'm very confident to say that my outcomes will be the same as if I had utilized my specialist colleagues, because of how old I am and the experience I have. But I'm able to do that at a reduced fee for them too. But if you got that patient that wants the Lamborghini and you're not the Lamborghini, you got to send them to the Lamborghini dealership. That's their choice. So you can't make that decision for them. You need to let them make that choice. So if you start bringing specialists into it, I know some of the specialists I use, their fee just to place the implant, I think, is $2,800. Plus there's the consult, plus plus sedation. So by the time they're done, it might be $3,500 for the consult, the surgical part, before they get back to you for a restoration. So now what's your restoration cost? Another $2,000, so you're $5,000. So I'm $3,000 to $3,500. That's how do people get those advertisements in the newspaper that do implants for $1,800 restored? I don't know.
I can chime in on that. I actually made that mistake early on in my career. And the mistake that I made was not knowing my margins. And as you mentioned, Steve, everything that you said was so golden. I wish I knew it when I first started. But the best advice that I can give you is don't cut your costs low, because of the fact that you have to, as Steve mentioned, you're going to have to at one point either repair or fix it. But the other thing too is that also know what your margins are, because if you know what your margins are, you know how much your time is and how much your parts cost and all these other things, you're going to know very quickly that charging $1,800 for an implant is going to put you at a deficit every time you go ahead and place them, right? So, and then the problem here is that, as Steve mentioned, if one of them goes wrong, then all of a sudden, not only did you lose money on it, but you just lost money on the next 3 that you're going to be placing as well. And one other thing too, that's the most important thing, is that if I went ahead and I placed an implant on this patient for, let's just say, $1,800, and then you recognize that you've made the mistake, and then a year later that person's wife even that same person comes up and says, I want the other side done, and you say, well, it's going to be $3,500, and then now you have to have a complete different conversation as to why it was $1,800 last year and today it's $3,500.
I will say, I mean, and that's we're on the same page.
Yeah.
So I will say that in hindsight, it's funny because a person I respect a lot in my practice is my business partner, Dr. Cece. He kind of chose his passion to be taking out aids. So he's graduate of 91. He's been out for a long time. He respected the curve. He spent years chairside just going in and observing oral surgeons in their office that let him go in, and he became very competent and very proficient at it. And he does very, we're talking money. I'm the last person to talk about money. I'm terrible with it. But if you're talking money, in hindsight, taking out eights, it's way more lucrative. You take out a set of eights, it takes him, I watch him in the office, it takes him 30 minutes to take out a set of eights, and it costs whatever it costs, $2,000. And guess what? It's finished. Those teeth are gone. They're gone, they're done, it's over. Whereas you do an implant and it's there, like I said, it's there forever. So you're married to it, and there's a lot of expenses that go along with it. So to me, the money part isn't, I don't do things for money. I do them because you like them. If you like it, you'll enjoy it. You'll be passionate about it. You'll be good at it. It can't just be about, it can't be all about economics.
So, and speaking about eights, before our next question here, we do have Neki Jamal that's going to be speaking to us this upcoming Friday at 12 p.m. And he'll be talking about simplifying tricky third molar extraction. So make sure that you guys tune in.
Perfect.
Yeah.
Perfect.
Okay, so last question. Somebody said, I was just wondering how Dr. Diana communicated with the patient in his last case, the one that you, the papilla was too short and you said it was kind of a mess. Yeah, just
Yeah. Well, let me tell you, I mean, I have not had a complaint at the college in 23 years and doing the things that I do. I think I'm pretty proud of that. And I'll tell you, that doesn't come down to the fact that I haven't made mistakes, because I'll show you mistakes. It comes down to 100% how you talk to people and how you manage things. So when you have something like that happen, you tell them straight out. It's like, and I'll tell you the error I made on that case. On that case, I'm a GP. I was utilizing one implant system in my practice, and it was the wrong implant system for that spot. That was an ankylosed implant. It was 3.5 in diameter. And it was put into a lateral position, and it was the wrong implant for there. I thought it would work, and it didn't, and I saw the consequence. So the bottom line is, talking to that young patient, that's a young patient too, right? That's congenitally missing lateral. You ultimately tell them straight out, you lost your papilla there and I can't get that back. And it has to do with the proximity of the implant to the adjacent tooth. I put the x-ray up and you show him and he's like, well, where else could it go? Because the space is pretty narrow. And you said, well, yeah, exactly. I mean, it's centered. Everything was good about it. I'm not going to start saying, well, I could have used the 3.0 there, because what was the point of going down that road? But you tell them, it's like, it's there. And the consequence was we lost a bit of bone. And so we're going to cosmetically blend it as best we can. And I don't know why this happens, but in also my 23 years of practice, these things tend to happen to the nicest people and the most understanding people. And maybe that's just been luck up until this point, but I also think it has to do with a little bit about how you present yourself to your patients in advance of doing things and in response to things. So it's combination. It's got to be a combination of how you talk to people and the luck of the draw, because the few things that have happened, the things that have happened that haven't been great, have always been to the nicest people.
And going back to what you said, Steve, and also to what Steve Chang said as well, the best way to shield and protect yourself is by proper treatment planning as well, right? I've always said this, and it's been true to me for so long, is to always inform before you perform. Because if you will go ahead and you say that space is an issue before you even place an implant, and then the patient gives you the green light to go ahead and place the implant, you know, it sucks that you don't get the results that you were expecting or hoping, and neither were they. But at the end of the day, now it's a team, and you both kind of are in it together. And you know, when you say to them, Mrs. Jones, we're so sorry we fell a little bit short here, or there's not enough space, they'd say the very common thing, say, you know what, Dr. Diana, you told me that, you gave me the heads up before you placed it, and I said go for it anyways. I totally understand. I'm still relatively happy with that. Versus not saying anything, and all of a sudden they come up and they talk to you about it, and you say, well, we didn't really have a lot of space here. And they say, well, Dr. Diana, you never really told me this, so now this is your fault, right? So, you know, if there's one pearl that I would give all of you young individuals or new grads out there, is to say, you know, always inform your patient, because it's never going to look like it's your mistake if you go ahead and do so and it doesn't turn out to be as ideal as you possibly would have hoped.
And on that note, this idea about what you said about not possibly as good as you would have hoped, you see all these cases that you see on these platforms that are so beautiful, and there's incredible cases. You know, beautiful cases aren't necessarily perfect cases. So it can't be perfect just because you want to be perfect. Sometimes it's going to be as good as it can be. And the important thing here, though, is identifying how good it can be before you do it and presenting that to the patient so they understand what the outcome is going to be. And that was the theme of our last talk, which was about predictability. How do you come up with a predictable outcome? And that's all in diagnostics. That's not in, I mean, the execution has to happen, but the execution should just be an extension of your hand at a certain point. But the predictability all comes from doing the proper diagnostics. And I thought Steve Chang's diagnostics with it, I didn't pay that money to go see him, get that sheet. So I'll screenshot it later and pilfer it.
Sounds good. Well, thank you guys so much. I'd like to thank our co-hosts for the day, Drs. Jay Carrier and Dr. Stephanie Clark. Thank you so much for your efforts. You guys did an absolutely phenomenal job. And I'd like to thank our speakers for the day, Dr. Stephen Chang and Dr. Stephen Diana. I know both presentations were made specifically for the DT Academy platform. So thank you guys for your effort, for your time, for everything that you do for us. And we appreciate all that you've done for us, for all of the community and our industry as a whole. So thank you all for joining us, and stay safe. And we look forward to seeing you all tomorrow at 11 a.m. Have a great day, everyone.
See you guys later.